two great trauma people in the country, Dr. West and Dr. Trunke. Dr. West is down in Southern California. Dr. Trunke's in San Francisco. And any two trauma surgeons in the same room are going to start comparing their outcomes. And that's exactly what the two of these folks did. They took 100 patients in their regional system and began to look at it. And the San Francisco group did much, much better than the group down in San Diego. So same state, same legislation, same enabling authority, but one group did a lot better. And the thing that I like about what they did is they then sat down and tried to break that into its constituent components and say, what is it? What is it about the San Francisco system that leads to a better outcome? And they began to write those things down as sort of optimal resources within a system, not only within a hospital, but within a system that lead to a better outcome. And that document was written up in a white paper. It was about 3 pages long, and it became the first sort of missaled or white paper adopted by the Committee on Trauma, a group that became the Committee on Trauma, and then adopted by the American College of Surgeons as the optimal resource document. Now, the college has sort of moved in a direction to work more on hospitals rather than on systems, but is coming back to the point where they're working on systems. But the first paper was really about system development, this white paper on your left, and it's had 7 iterations so far. And as Allison said, we just finished rolling out the orange book, or the 7th iteration of that book of optimal resources for the care of trauma patients. So it's continued to evolve over a 45 year period. But back to California. So they identified optimal resources in both San Diego, Southern California, and then in the Bay Area in San Francisco, and began to implement them. And so 1970, the mid-70s until the late 80s, about a 14-year period in both of those places. And then they did preventable mortality studies. I think this is one of the most valuable tools in a system that you can possibly do. It's a modified Delphi process where you take people from every level of the system. So you take nurses from a level 4 from a small referring hospitals, you take flight medics, you take trauma surgeons from the level 1, you take legislators, you take public health people, and you put them in a room and you take all of the death charts from a region for a period of time, and you have a statistician put them into buckets so that you get statistically representative samples, enough peds, enough adults, enough penetrating, enough blunt, enough urban, enough rural, so that you're not misrepresenting. It's a statistically representative sample of your region that you're looking at, and then you go through the chart line by line, just like you do when you review your trauma charts, or just like we do here in M&M, like this, and you review them. And you are going to first adjudicate them as frankly preventable, potentially preventable, preventable with opportunities for improvement, or care appropriate. And then you're supposed to identify those opportunities for improvement within the system and list them out and put them into buckets so that at the end of it you can say, well, in the pre-hospital arena, here's what they were. In the operative arena, in the ER, here's what they were. In the post-op acute care, here's what the opportunities were, and put them there. And so this was the first time nationally such a broad-scoped Delphi process was used, modified Delphi process was used for a preventable mortality study. And so Dr. West and Dr. Trunke did this about 14 years into the system, and they showed over a 50% reduction in preventable mortality. Take any other surgical disease, take breast disease, take vascular disease, take oncologic disease, take any of it, and show me where you've seen a 50% reduction in the mortality in that disease process in a 14-year period. It just doesn't exist. And so this is revolutionary, and it really had less to do with what we did technically as to what we did at a system level. And it took physicians like Dr. West and Dr. Trunke leading this charge, working with the public health people to affect this kind of change. So I'll get back to this, but if you don't think that you have an opportunity in your life to make a difference in public health and people's health in your area, in your region, the place where you live, you're wrong. You've got a tremendous opportunity. I would have never thought it 15, 17 years ago when we met, and my journey sort of proven that that's really an incredible possibility. That preventable mortality study has been repeated several times. Nels and Terry Sandel did this in Montana in the 90s, showed about the same thing, a 50% reduction. Dr. Trunke, when he moved from San Francisco to Portland, Oregon, did it again, and over about a 10 or 12-year period shows this 50% reduction. Terry and Nels Sandel did it again in Utah. And then we just completed a preventable mortality study. Our pre-assessment was in 2009. Our post-assessment was in 2014. And in a 5-year period in the state of Arkansas, we had a 50% reduction in preventable mortality. What's interesting about that is that's wonderful. And to public health people, that's a big deal. You know, there's a lot of people that are alive today that wouldn't have been alive had we not implemented a system. And that's pertinent to those of us who have to walk into that little room after the post-resuscitation and sit and look a family in the eye and tell them that a loved one did or didn't survive. That's a big deal to us. From a policy standpoint, those lives saved in the state of Arkansas translate into people that go back to productive life. They pay taxes. They don't use resources in the rest of the system over the rest of their lives. And we have a health economist that estimates our return on investment at about 5 or 5.5 fold. We estimate that for the $19 million that we receive annually, we return the state about $105 million annually in those benefits, those cost-saving benefits back to the state. So no matter who you're appealing to, the public health side, the humanistic side, the folks that have to look families in the eye like us, or the people that have to look after the fiscal health of a state and a system, this makes good sense. Trauma systems make good sense, and they're worth investing money in. As a matter of fact, you almost can't afford not to invest the money in them. So we've enjoyed a tremendous savings. There were some themes that came out from our preventable mortality study. And if you go back and compare it to other preventable mortality studies and other systems developments, I think these themes become consistent. And so that's sort of the basis of the talk, is what is it about a system that makes it work? And it goes back to the giants like Dr. Trunke, certainly before us, but we found several things. First is, you really do have to make an investment. You have to get the legislation and the people of your region or your state or your province to make an investment in that savings. Somebody had to front the first $19 million and probably the second $19 million and probably the third $19 million in order to enjoy, finally, once the system was built, this $105 million return on investment. So it really was sort of a bet among the state to invest in that and to get something back. But you have to convince them to do that. We'll talk a little about that. Where does that money come from? What's a reasonable way to do that? There is a steep learning curve. You leave these hallowed walls, and very quickly, if your practice is not trauma, critical care, acute care surgery, you can lose some of those skills. And as quickly as things have advanced, we've been in one of these periods of conflict where things have advanced rapidly. And over the last 15, 20 years, if you were out of training like I've been, and I hadn't been in an environment like that, if I were doing general surgery in a community, it would not be hard and not sort of no indictment on my skill or my intellect that I have not kept up with that. So there was a tremendous educational need throughout the state. What we realized also, and I'll suspect it's just like here, is that we put on classes here in the ivory towers. We put on ATLS and TNCC and ADAM and ASSET. We put on all those courses, and we'd have the same group of people that would come through every few years and recertify, but we were not reaching the majority of the emergency medicine docs, family medicine docs, because there actually aren't that many emergency medicine docs in the state, general surgeons. We were not reaching them. So what we did in the state was we put together an educational foundation, and we bought a van. And we load the van up with the mannequins. We load the van up with the educational equipment. And we now teach one ATLS class in Little Rock annually, and we teach the other 9 in the other cities around the state. We taught more rural trauma team development courses last year than any state in the country. We taught 11 of them, and that puts me and the chief of trauma, Allison's counterpoint at the university hospital, that puts us in the small hospital. So we understand what it's like. We got to go to that hospital that sent that vascular patient and talk to them about limited fluid resuscitation, about tourniquet use, about the use of plasma, about communicating with us faster, about not scanning if the scans weren't going to make a difference in the outcome of the patient, just sending them. We get to meet them face to face. I know their name now, and we get to give them that educational opportunity. That has made a huge difference for us. The last thing is that you need a standard, and while you have to adhere to a national standard, you have to demonstrate a little bit of flexibility. This is exactly what we've been talking about last night and again this morning. I'm a little schizophrenic. I do chair, the vice chair of the Verification Review Committee for the college, which has a very rigid standard. And just to let you in on the dirty secret about that, I don't mind saying it. It's a consensus group. You get in a room and you say, okay, where's the data? And we pull out as much data as we can, and we try to do things we think make sense, and we try to use expert opinion to write new rules or to change new rules to keep things modern. And we do it when we have data. We use the data to do that. But it really is a group of experts. And so I'll get back to this later. But again, if you don't think that you have opportunity in your life to make significant changes, a lot of that is just going to the meeting, just showing up, and just devoting your time and effort to that. So you really do have opportunity. So it's consensus, and I'll tell you that it's important to have that as a standard out there. But one of the impetus is there's politics involved in that. I know that's shocking to you, but there's politics involved in that. And a lot of the changes that you see presently in the Orange Book, the changes from the Green Book to the Orange Book, the standards, really had to do with the concern among urban hospitals being encroached on by the for-profit hospital systems, putting up level 2s in the suburbia to cut off ingress into the academic trauma center. That's why the standards got up so significantly, particularly for level 2. Well, that's good. That solves a problem. It's a problem in Miami. It's a problem in Tampa for HCA to go put hospitals all in the community and cut off ingress into those hospitals. That's a problem for training. It's a problem. Volume equals outcome. That's true. And so that is a problem. Where it hurts us is in Arkansas and West Virginia, when the level 2s have standards that are unrealistic and can't be met, and there's no flexibility in that system. So I think while it's important to look to national rules, it's also important to have a little bit of local control over those rules and opportunities. And then I think data. The data helps because what was fascinating, I'll talk about this in a little bit, but there's a very predictable life span to a trauma medical director, be it a state trauma medical director or a hospital trauma medical director. They're all so happy when you're coming, because in the back of their head what they're saying is good, she's coming, and what she's going to do when she gets here is beat up everybody else that's been getting in my way and keeping me from delivering great trauma care. That's what's going to happen when she comes. And then she gets there and she looks around and she says, and the data comes out, and actually she comes to you and says, you're part of the problem. You've got to change your process, and then everybody hates you. There's a period where everybody just can't stand you for a period, and we saw that in the state. They were so happy we were going to come, and we were going to set the system up, things were going to get immediately better. You've got to beat up the EMS people. You've got to beat up the level 3 hospitals that aren't keeping the people. You've got to beat up the level 1s that won't ever take our patient. That was what was said. You're shaking. You've lived this, haven't you? But it really was that every link in our chain had to be strengthened, had to be changed fundamentally in order for the highest mortality in the country to be reduced by 50%. Changing the hospital wasn't going to do it. Changing EMS individually wasn't going to do it. It really had to do that. And the last, I think, major lesson that I learned is the importance of buy-in. And so our stakeholder group, made up of medical students, residents, community people, clergy, level 1, level 2, level 3, level 4, flight people, legislators, and involving them in the data analysis part of our system was what was important to get them to buy in and continue to support this system. We've had a very drastic political change in the state of Arkansas. We were born under a Democratic governor and Democratic legislature. We now have a very fiscally and socially conservative Republican governor and Republican legislature, and we have thrived under both of those because we found ways to engage them in the process of rulemaking and the system. The first thing that has to happen in the system is somebody has to give you permission to do what you're trying to do. It's interesting. We talked about this last night, but the private citizen, I can go do whatever I want to do unless there's a law that keeps me from doing it. A state agency can do nothing unless there is a law that enables them to go do something. And so your legislature has to give a lead agency, typically a Department of Health or an Office of EMS, or they have to give somebody the authority to go out and create a system. The lead agency then has to have the authority to set rules and not only designate hospitals, but probably as important, de-designate hospitals. We talked a little bit about this on the way in this morning. To be a certificate of need state is a mixed blessing, right? It may keep you from building ICUs, but it also allows you to say, well, we're not going to be encroached upon by unnecessary profiteering hospitals trying to cut off ingress into the trauma center. So it's important to have that authority, whether it's executed or not. There needs to be a state performance improvement process. What you just witnessed is fairly rare. You just witnessed somebody come sit down and take their case and open it up to criticism and to scrutiny by a group of peers. That's unusual. That doesn't happen in industry anywhere else. It damn sure doesn't happen in state government anywhere. We are not transparent as a state government. What you saw is unusual. But if you want to make a healthcare system in a state better, you've got to be able to do that. You've got to be able to take out of a hospital, which makes the hospital attorneys just apoplectic, to take cases, actual patient care, out of a hospital, out of an EMS system, out of a region, and put it on a table in front of everybody else and say, where are our opportunities for improvement? How can we improve this? We were fortunate in the state in that we had in the enabling legislation indemnity. We have protection from the Freedom of Information Act if a process is being done as part of quality assurance for the state. So we actually take cases. We take cases that span from pre-hospital to first hospital to transport to second hospital to rehab, and we examine them in a statewide M&M, just like you saw here, and we go at it just like that. Where were our opportunities? What were the real reasons? We don't wash stuff under the carpet, and we don't sugarcoat it. And through that process, we find ways to make the system better. That has been one of the greatest opportunities that we've had. We've also viewed it really as a public health issue. We have hospitals presently, so we have 72 hospitals in the whole state. And they all got designated at first because there was some money attached to it, and now when those standards got raised, a few of them said, hey, well, wait a minute, that's a little more than we were interested in doing. And our question from the Department of Health is well, what are we going to do about that? And my boss at the Department of Health, the state health officer, says if there were a threat, if there were an infectious disease threat to a community, we would be obligated ethically, morally obligated to go to that community and warn them about this impending health threat. We're going to do the same about hospitals that you believe, Todd, are not going to pass the designation process. We're going to go to their elected official, we're going to go to the paper, we're going to go to the public, and we're going to say we have concern about the quality of care or the ability to protect public health in your community, and we're going to let the community put a little bit of pressure on the hospitals in order to keep them up to standards and keep them into the system. Unheard of in trauma systems across the country. And then I do think, while I have a little anxiety about, we have money, the trauma system has money, and we have a little momentum, I have a little anxiety about incorporating other time-sensitive diseases. In the big picture, that's right. I suspect it's the same in West Virginia. Our mortality that was the highest in the country in trauma is near the highest in the country for cardiovascular disease and for stroke and for STEMI, and our processes for dealing with that are just as antiquated as they were for trauma 7 years ago. And so I think there is an economy of scale of putting together those time-sensitive diseases. If you can designate a hospital for trauma, they can be designated for STEMI. If you've got an effective communication and transport process for trauma, you can probably make it happen for strokes in the state too. And so rather than let those develop in silos, it really is going to be better for us to develop those together. So, and I think one of the things has been to refute this isolationism of, well, it's West Virginia, well, it's Kentucky, well, it's Arkansas. We're poor, we're rural, there's long distances, the weather can be bad. I think that's where it's nice to have sort of some collaboration. I think that's where it's nice to have risk-adjusted benchmarking across the country that has some flexibility, so that I can put our numbers on the table and say, well, I've been to Morgantown, West Virginia, and I'm going to tell you, it looks a lot like Fayetteville, Arkansas. And the weather's bad at times, and it's hilly, and there's places where it's hard to get to people. There's small hospitals that don't have emergency medicine trained physicians staffing their ERs. So there's actually not that much that's unique about Arkansas. There's every reason why we should be able to do this at a standard. And to put that data on the table breaks down some of that isolationism and keeps us from settling for mediocrity. And I really have sort of mentioned it earlier. This is the recent standards from the American College of Surgeons. I think it's good to use that as a basis. And I don't care whether it's a designation as a pediatric surgical center, which is about to come out, a neonatal center, ambulatory care center, or a trauma center. I think a group of people that try to be above the local politics and write sort of a standard, a best practice standard, is necessary. It's at least necessary to start with that. Now, you may want to modify this for what's unique or doable in West Virginia or Arkansas, but I do think that it's helpful to start with the highest standard rather than start with the state standard. And that's been one of our lessons learned. It does matter, and it matters within the state, even though there are some unique things about West Virginia and Kentucky and Arkansas and Wyoming that you might want to change the standards. There is no doubt that putting the standards on the table and then finding a way to adhere to them drives quality. It does. These papers have all been published, and they've been published in every kind of place, urban and rural, big sort of swaths of the country, where being a non-trauma center, you do better at a trauma center than a non-trauma center. You do better at a level 1 than at a level 2, despite what we've always said with the American College of Surgeons. You do better at a level 1, level 2. And does a patient really do better because we do research at a level 1? No. They do better because of all of the people that come to a level 1 to do that kind of work. I think there's just an intensity there that's almost hard to quantify that's different to it. And we're getting to a point where even among level 1s, the criteria really are about process. We check off boxes. You know, if you can get a surgeon to the trauma bay within 15 minutes, you check a box. If you've got this piece of equipment, you check a box. If enough people have gone to TNCC, you check a box. Where we really need to go is to outcome. And we need to marry process and outcome together to say, okay, if you have very high process scores and very high outcome scores, great, you're good. If you've got very low process and very low outcome, you're not so good. You got to do something. We're not going to designate you. It's those two in between that we're kind of struggling with, and that's where the College of Surgeons, that's where we're moving. Is to try to marry our process and our outcomes. There's a reason to do this, and the first slide is about hospitals, but I think it carries over into systems. When you get a system up and going, there's a Hawthorne effect throughout the whole system. We've looked already at stroke and STEMI in our state. We have no stroke and STEMI process in our state. Program, verification, designation. We don't have it. But stroke and STEMI mortalities are coming down. And they're coming down faster than they're coming down in the rest of the country because we're learning about time-sensitive diseases and we're getting better about moving people through a system because of trauma. There is a halo effect both in a hospital and in a system to the development of an effective trauma program in both of those places. So I think at times, you'll appreciate this, I think at times, the Department of Health and the hospitals think you're sort of, we're sort of at that phase where not everybody likes me, and they're sort of think we're picking on them to continually drive them to that highest standard. But I think that's where our calling is as the public, as the sort of protectors of public health in the state of Arkansas. That's our calling, is to continue to drive them as high as possible, but realize and recognize where there's a breaking point, and to keep hospitals, EMS services, public interest in the system. I think that's really our challenge, and so that's what we're working on. You asked me earlier, where do you get the money? Where do you get the money from it? And this is a tricky thing, and I think we've learned a couple of lessons there. The easy thing to do is sin tax, because the people that, the smokers don't typically, the people that have had DWI don't typically, people that visit your hotels from out of town don't typically have an organized lobby with which to argue against a tax. And so that's typically where we put that. Interesting note, in Houston, we funded the system off of a driver responsibility bill, so that when I ran a red light or I ran through a stop sign, I got some points on my license and I had to pay it at the end of the year, and that's what went to fund the trauma system. And that went over okay. Then we instituted red light cameras, and that became a huge problem because the municipalities outside of the major trauma center said, well, wait a minute, you want us to buy a camera, a few $100,000 to buy the camera, maintain it, write the tickets, collect the money, process it through our county system, and then send it to Morgantown so that y'all can take care of a bunch of gangbangers. That was sort of the theory in Houston, Texas, around Houston, Texas, and I'm telling you, that failed miserably. So just another example of, in my altruistic public health mind, I may not anticipate all the unintended consequences, but it's helpful to have stakeholders around the table as you begin to think about these things, because you can't imagine where the opposition might come. So it ends up being the path of least resistance. So in Arkansas, it's a sin tax with the path of least resistance was tobacco. So we have $1 a pack tax on tobacco, and that's what funds our $19 million of revenue. Interestingly, with the advent over the last few years of vaping and e-cigarettes, we've lost revenue. So people aren't smoking any less. They're not getting less nicotine in Arkansas. They're still dying of their cardiovascular disease. But we're losing the revenue, so we're going to have to go back and rethink some of that. But those are challenges within a system. There's also this sense that from the hospitals and the system that you don't want to become a trauma system, because if I don't become a trauma system, a trauma center, they won't come. That that right outside your county or your municipality are a bunch of ugly, drunk, no pay, no insurance folks. That the minute you become a trauma center and put the light on, all these folks are going to get in the bus and descend on your trauma center. Well, of course that's not true. They're coming anyway. They're coming, and you don't know the impact. You don't know the impact because you don't quantify it very well. They're coming. They're creating a burden because there's nothing organized. They're incurring costs. They're incurring revenue, and it's just we're not saving anything because the system's not put together in any way. And so this was sort of a weird misconception that we had to refute early on. The other one is what were we paying for? I'll just say it. It was felt in the rest of Arkansas that what we were doing was funding the university hospital to take care of African American gangbangers. That was what was felt. Because when they trained in Little Rock in the 90s, it had been a violent place, and that's what they remembered every night. Well, sure, I remember the gunshot wound to the cava that we took care of at Bentob, and I've probably forgotten the other 4,000 or 5,000, insured citizens that I took care of with blunt injury that had a tremendous margin for our hospital. So we've done a really good job, I think, of showing what the demographic of trauma is. The trauma patient in Arkansas looks like me. They're overweight. They're 50 years old. They have insurance. They have a job. They're driving a car, and they crash. And that's who it is. Or it's the 65-year-old who falls at home and is on Plavix. That's our trauma population in the state of Arkansas. Actually, our penetrating injury rate is lower than the national average. The demographic of our trauma patient population is much more Caucasian, much more insured, much more rural than the rest of the state, than the state demographic is. And so it's very, very important to get that message out about what it is we're doing. We're actually, yes, I'm proud to get to take care of interpersonal violence in Little Rock, Arkansas. I'm privileged to get to do that, but I'm also glad that we're taking care of the public health of my in-laws who live in a rural place and periodically crash their car. That's what I'm happy to be able to do. There are multiple ways to fund a system other than just take the money from the state. It's good to get infrastructure money from the state, but it's not intended to pay for care. Trauma care makes money. Trauma care makes money. And I think that was a misconception early. It's procedural. It's typically young folks. It's typically drives through the system. And if you've got a good system like you've got here that has people that sort of get up every day and take ownership of the patient, move them through the system, then it makes money. And so helping hospitals and helping systems realize that will also drive your program. What you want money from the state to do, what you want money from a lead agency to do, is to fund the unfunded portion of your program that there's no bill that you can turn things in for. So a little stipend comes to the university for me, for a trauma medical director for the system. A little bit goes for the infrastructure of our trauma registry at the state. A little bit goes for the meetings in which we get together and do this performance improvement. There's no opportunity anywhere in the billing or collecting to get that money back, and that's what you actually need the money for. Interestingly, of our $19 million annually, only about $6 million goes for that infrastructure. The rest of it is slush money, quite frankly. It goes to hospitals, it goes to EMS agencies, it goes to buy participation. And if you could mandate participation, you could run our state trauma system on about $6 million a year. So actually a pretty small amount, again, for the 150 that we return back to the state. The data sets you free. It changes the whole discussion from one of emotion, in which I'm sure that those no good level 3 hospitals are just sending every patient out that because they don't want to take care of them, or it changed, and EMS will never come in a timely manner and pick our patients up, and they dwell in the outside ED too long. It changes that to a data-driven discussion. And I think typically we do this backwards. We have a state trauma registry that collects data, and then all of a sudden people come along and go, well, it really would be helpful to know how many high ISS patients are dwelling in an outside hospital greater than 4 hours. And the state registry says, well, that's not a data element we collect. And so the opportunity that we had, one of the real benefits we had, was to start from scratch and name the outcome metrics first, and then build the registry so that it captured those things. So now in a 6-year period, we have a very, very high functioning registry. Everybody works off the same registry. EMS all now works off the same registry. We can link all of those data elements so that we can ask questions across the system. And we have a robust system outcome metrics group that defines and changes annually what those outcome metrics are, and that's what drives our registry. So that really has helped us quite a bit. Who's the QI person? Who's the trauma folks that do QI and do PI? Yep, bless your heart. As we say in Arkansas, that has a lot of meaning, but bless your heart. You say that when somebody has an ugly baby. We say that all the time. Well, bless its heart. But there's nothing intuitive about. I mean, have you had your PI class in medical school? No, there is no PI class in medical school or nursing school or anything. There's nothing intuitive about this process. It's an evolutionary process. You learn to take data, look at it differently. You looked at it this morning sort of clinically for opportunities for improvement, but you look at it differently now. You look at it from a system standpoint, where there are opportunities, not only clinical opportunities, but system opportunities for improvement. And this is not easy. It takes time. It takes dedication from the institution or from the system to allow people to learn this skill, practice this skill, and really develop it. So we've had a tough time in our state with this. We have 72 hospitals in the state. We have turned over 101 trauma program managers in the first 5 years of the system. 101. Because they get in because somebody in the hospital makes them do it, and they go, well, hell, this is hard. And and the hospital doesn't give them any support or any training, and they do it for a while, and then their survey comes around, they do terribly, and they leave. They get fed up and leave. And so we at the state level have created sort of a support group for them. They have their own group. We have classes that we put on from the state for them. They're online. We go out to the hospitals and do that. And so supporting the QI process in hospitals and within the system has really been an evolutionary process. And again, back to data, once you do the QI, it's important to be transparent about it, and it's important to not be insular and to not just look. Again, Arkansas Children's Hospital just has a mortality rate of 1.28%. Well, sure they do. Again, nobody that was that sick lived to get to Arkansas Children's Hospital. So risk-adjusted benchmarking was what was necessary. So our ISS was lower than other children's hospitals because nobody made it. Our time to door, our time to OR was 6.5, 7 hours. And so physiologically they were winners. So we weren't comparing apples to apples when you made that statement that our outcomes were better than the rest of the country. And it's only through this risk adjustment model that's been a recent thing that we've really begun to learn this. And I think you're going to see this all over the place. The American College of Surgeons is dedicated to risk-adjusted benchmarking in bariatric surgery and vascular surgery and pediatric surgery and trauma surgery. And what you're going to see is they're going to bundle all those things together and offer you QIPs, different quality improvement program packages, and designations in a bunch of areas, sort of all packaged together. And it's important to be transparent. We work with our paper. We work with the radio. We work with the news outlets. I don't think as a group we're very self-aggrandizing. We may be boisterous among ourselves, but we don't toot our own horn very much. And I think it's important for your neighbors who gave you the money to start the system, quite frankly, through their taxes. I think it's important to give them back an accounting of how the system is doing. And so the transparency, level of transparency is a little foreign to us and doesn't feel very good because this is kind of not who we are, but it's important to do. It's really important to do. And I think engagement of the legislature, engagement of the community through the media outlets is important. It gets everybody sort of pulling in the same way. And again, through this very big change in political change in Arkansas, we're doing better now than we were when we started. And that I don't think any of us would have predicted, but I think it's due to the wisdom of getting the public and the legislature pulling in the same direction. Lastly, this is Lewis and Clark. So Meriwether Lewis is actually Colonel Clark was the leader of the expedition, and he really was the mastermind behind it. And he got no credit because Lewis Meriwether was the one that wrote the book about it. And so my point here really is publish your results. Publish your results and let other people learn from it. When we were setting up the system, there was very little except Trunky and West from 30 years ago that I could go to as a model. And I could call friends around the country and they'd give me anecdotal. There was very little I could go to learn, to see how to do this. And subsequently, we've published a lot about lessons learned from our system and opportunities. We've shown that teaching the rural trauma team development decreases dwell time in our level 4 hospitals by 27 minutes. We've looked at our call center and its effect on dwell times. We've looked at our hand telemedicine program. We've looked at helicopter transports, and we're about to publish our preventable mortality study. I think that that's important to do, not necessarily for your personal self-aggrandizement, but because it helps drive systems throughout the rest of the country who are struggling, looking for best practices that they don't really get. I talked about the predictable lifespan of the medical director already, so I won't belabor that. I'll just give you heart that if you think you might want to do this at some point, you will come out on the other side. And actually then people beat you up because if anything ever looks like it might go back to the way it was before. So, that's what they yell at you now about. So that part's kind of fun. I talked about this already. We are going to move from counting widgets and counting things to looking at quality outcome, and we're going to incorporate that into the designation process, so that probably the way it's going to look is that if you are a high performer and you have good process, we'll probably lengthen your designation period out significantly and not visit you as frequently. That may be the real benefit there. I'll come back to you guys. It really is true. It really is true. It's been true in my life, and it will continue to be true in your life. It will be that you have a bully pulpit. Your training gives you a bully pulpit from which to stand up in your community and your hospitals and make a change. The legislators listen to you. The state agencies listen to you. Your colleagues listen to you, and you just have to put in time. I am the least talented pediatric surgeon in the state of Arkansas. I truly am. I don't even know that I'm that good, really. But I've made a big difference in the health of pediatric patients in the state of Arkansas because I go to the meetings, I show up, I took an opportunity to work some in the public health arena doing that, and it's been a very rewarding life. It's been a very rewarding career. I didn't plan it. It was serendipity, but it's been wonderful, and you will have those same opportunities. And when you read that book, Humans Are Underrated, you'll see that that's one of the great opportunities that's going to continue to exist in the coming few decades. So, quick summary. There are some key ingredients to a state system that really must be in place for them to work. I've done the regression analysis of all of them, and you've got to have some of those key ingredients that we talked about. Money is one of them. You cannot do this as an unfunded mandate. But I'm not sure it takes as much as we, the hospitals, would lead the system to believe. You need the infrastructure, but not a lot more. Not a lot more than that. You got to have a few people strategically positioned throughout the system that have a vision and don't waver from it. We were so lucky in our lives. We were apostles of Ken Maddox, and there is nobody ever that had a greater vision for what trauma surgery, acute care surgery, general surgery could be in the United States than Ken Maddox. So we were mentored well in that. You got to measure your outcomes, and you got to report not only to your colleagues in the scientific journals, in the Journal of Trauma, but I got to report it in the Arkansas Democrat Gazette, the paper, as well. That's what keeps us moving. And then you just have to get up every day and realize you're going to get beat up some days, and you're going to get right back up and get after it. But at the end of the day, it'll really be worth it. For me, there's a reason to do it. There's a reason to get up and do it every day. So again, thank you for an incredible couple of days here. Thanks for the opportunity to come share this with you. Thanks for what you're doing in the state of West Virginia. Thanks.